Good night, everyone. Today we have a very important lecture, spinal cord ischemia, and we have 10 tips to protect for spinal cord ischemia and subsequent complications. And first, we have to start to talk about what are blood supply arteries of spinal cord. We have anterior spinal artery, posterior spinal artery, right and left, and segmental arteries. The most important artery of Adam Fix started from left side in 80% of the population at the level of T5 to T8 in 15% of the cases only. The most common site at the level of T9 to T12 in 75% and the least percent at the lumbar. We have segmental artery intercostal and segmental artery for lumbar and collaterals from the internal iliac artery, and from the segmental artery it will give branches like radicular arteries and segmental medullary arteries. So it's important before you have to make your thoracic aortic aneurysm repair or open repair to detect the blood supply of the spinal cord. For example, in the open repair of aortic aneurysm, you have major lumbar artery. You have to make re-anastomosis for it, for example. So we will discuss every artery as individual case. We have anterior spinal artery, posterior spinal artery, segmental artery, artery of Adam Victim, intercostal lumbar and collateral from the internal iliac, and great radicular anterior segmental medullary artery. And those segmental artery give branches like radicular artery and medullary arteries. This is a picture of spinal cord blood supply arteries. We have here vertebral artery, anterior spinal artery, and we have intercostal and lumbar and branches from the internal iliac. This is the connection of the both vertebral artery to give basilar artery, which share in the circle of Willis. This is the posterior spinal artery from the posterior side, ascending cervical artery, some intercostal artery, and lumbars. And this picture of the anterior spinal artery and some radicular arteries and how it make anastomosis to supply spinal cords. Vertebral artery is the first branch of the subclavian artery. Anatomically, it is divided into 4 regions. The first part runs in the foramen in the transverse process of the C-section. Anterior to this part lie the vertebral and internal jugular veins. The second part runs superior through the foramen of the transverse process of the upper C-section cervical vertebrae. The third part runs posteromedial on the lateral mass of the atlas, and it enters to the suboccipital triangle. And the fourth part passes through the spinal dura and arachnoid, running superior and anterior to the lateral aspect of the medulla oblongata, and at the lower border of the bones it units to form basilar artery. This is the segments of the vertebral artery. So the first segment in the transverse process of the C-section, the second segment between the transverse process of the upper, the first segment between the branch of the subclavian to the transverse process of the C-section, second part within the transverse process of the C-section, and third part and then fourth part in uniting to form basilar artery. So what are the branches for the anterior spinal? The branches of the vertebral artery, anterior spinal artery, and posterior spinal artery, and also posterior inferior cerebellar artery, which is the largest branch of the cerebellar arteries. So what's the basilar artery? Basilar artery doesn't share in the spinal cord blood supply, but it shares in the 4 circle of Willis, and it's really important. Being when you are including this subclavian, you have to assess circle of Willis. Basilar artery forming and the lower part of bones by uniting of the 2 vertebral artery, and give branches of anterior inferior cerebellar and labyrinthine artery and pontine arteries, superior cerebellar artery, and posterior cerebral artery. and then it will be shared in the circle of Willis, which is the forming of the anterior communicating anterior cerebral, and then we have internal carotid artery, and we have also the posterior communicating artery. So branches of the vertebral artery. Vertebral artery, we have told that there are four segments. First segment between left subclavian and transverse process of the C-section. Second, between all through the transverse process of the cervical vertebrae. Third and fourth, third to the subacromial space, and fourth to unit to form the basilar artery. It has a branch of the anterior spinal single artery, posterior spinal two artery, right and left, and posterior inferior cerebellar artery. Basilar has an anterior inferior cerebellar artery, labyrinth artery and pontine arteries, superior cerebellar artery, and posterior cerebral artery. Anterior spinal artery origin, branch of right and left vertebral artery in the upper cervical canal. Course, run caudal in the anterior median fissure. Termination, filum terminal, supply to the anterior two-thirds of the spinal cord. Posterior spinal artery, we have two arteries. Origin, branch from the vertebral artery or posterior inferior cerebellar artery. Course, run down in the posterolateral sulcus, divided into two collateral arteries, medial and lateral, along the posterior nerve root. These communicate around the cord, forming bile plexus, arterial basocrona, arterial corona. Supply posterior one-third of the spinal cord. This is the picture of the vertebral artery and uniting to form basilar artery, and this is the anterior spinal artery, but this is the reverse picture. And then we have also posterior inferior cerebral artery, maybe a source of the posterior spinal artery. Posterior spinal artery either starting from the posterior inferior cerebral artery or directly from the vertebral artery. And we have two posterior spinal artery, right and left. And this is the segmental artery. Maybe it's intercostal, maybe it's lumbar, maybe it's collateral from the internal iliac. And it then give branches of the radicular arteries, posterior and anterior radicular artery, and we have also some medullary arteries. This is the branches and the blood supply of the spinal cord. So anterior spinal artery, single artery arising from the vertebra, posterior spinal artery arising from the vertebra or posterior inferior cerebral artery, which is a branch from the vertebral artery, segmental artery, intercostal, lumbar, and then we have radicular arteries and medullary spinal arteries. Internal iliac artery, which share in the spinal cord blood supply. And first we have to detect what are the branches of the internal iliac artery, and we have this very good mnemonics. I love going place in my very old underground. I love going place. I love going. This is from the posterior division. I for iliolumbar, L for lateral sacral, G for superior gluteal. And from the anterior division, in my very old underground, we have B for pudendal internal, inferior vesical uterine in female, middle rectal, vaginal, obturator, and umbilical. So the branches of the internal iliac artery from the posterior division, iliolumbar, lateral sacral, and gluteal superior. And the branch from the anterior division, pudendal, inferior vesical, middle rectal, vaginal, obturator, and umbilical. I have gone places in my very old underground. So this is the picture of the internal iliac artery, and we have here the posterior segment, which give the lateral sacral, iliofemoral, and superior gluteal, and we had the anterior division, which give the major branches and other branches for the internal iliac artery. So how to decrease the risk of the spinal cord ischemia and subsequent complication? We have 10 tips in this presentation. We will discuss it thoroughly to detect how we can decrease the risk of the spinal cord ischemia. The first, CSF drainage. We have to optimize the spinal cord perfusion by raising the arterial systemic blood pressure and reducing cerebrospinal fluid pressure and central venous pressure. You have to make the pressure equal or less than 10 mmHg for at least 48 hours and continue monitoring in a recumbent position to avoid subdural bleeding. And later on, either you have to remove it after 48 hours or in case of spinal cord ischemia, drop the pressure to be less than 5 mmHg. What is the guidelines and recommendation? According to the most guidelines, which has been published at 2010, cerebrospinal fluid drainage is recommended as a spinal cord protective strategy in open and endovascular thoracic aortic repair for patients at high risk of spinal cord ischemia injury. Class 1, level of evidence B. Second step, early pelvic and limb perfusion. In open surgery, you have to make a left heart bypass in case of thoracic AAA to maintain lower limb perfusion. In endovascular, immediate complete deployment of the bifurcated body and limb extension. Withdraw a large caliber sheet as early as possible to restore blood flow to lower limb and pelvis. Third tip is post-operative blood, fresh flows in plasma, and platelet transfusion. Keep hemoglobin more than 10 gram per deciliter, fibrinogen more than 10 gram per liter, platelet more than 100,000, and avoid post-operative coagulopathy. Hemodynamics. This is the fourth tips. Volume resuscitation expander and vasoactive support should be available. Mean arterial pressure is between 85 to 90 mmHg per permissive hypertension. Hemodynamic stability is very important. The surgeon play a major role to ensure control of hemorrhage intra and post-operative. 5. Moderate heparinization and neuroprotective drugs. 1 mg per kg heparin to prevent embolization and thrombosis. Administration of different neuroprotective agents, methyl, prednisolone, mannitol, lidocaine, and thiopental, to treat spinal cord ischemia, but has not been proven as evidence-based medicine that it has a diet risk, but maybe has a protective role, but we don't have evidence about this point. However, edema-reducing drug could have a role in increased spinal cord against ischemia reperfusion injury. And we for scientists and researcher, not for myself. Number 6, maintain permissive mild hypothermia, 32-35 degree nasopharyngeal, and selective epidural cooling cold saline 3 degree infusion. This is the 6 steps to decrease risk of spinal cord ischemia. Maintain permissive mild hypothermia and selective epidural cooling. Number 7. Renal artery perfusion during open AAA repair using 4 degree cold custodiol or crystalloid solution to do a membrane stabilization and inhibit excitatory neurotransmitter, and custodiol solution which has proteins and potassium and sodium, and it is very effective in a comparison with the crystalloid and blood to decrease risk of renal ischemia. Number 8, mesenteric artery perfusion by blood flow from left heart bypass. During repair of the thoracic aortic aneurysm, you have to maintain perfusion for the visceral artery, and it could have a source from the left heart bypass to decrease post-operative coagulopathy and bacteria translocation. Number 9, staged operation, and in this point we will discuss it thoroughly. Try to maintain one internal iliac artery and preserve it. If you are going to occlude both, it is better to be staged with a 2 week space in between. Okay, the circulation after ligature of the internal iliac artery is carried on by the anastomosis of middle rectal and superior rectal artery, iliolumbar with last lumbar artery, and lateral sacral with a median sacral artery. And this is a collateral after you have occluded internal iliac. You have a direct connection from the iliolumbar with the last lumbar artery and intercostal. And this connection between the external iliac artery and some visceral artery. Okay, so the recommendation is to make a spacing between internal iliac artery occlusion if you are going to occlude both, or it's better to preserve for one. What's the risk, or what are the risks after you have occlude internal iliac artery in both sides, coronary ischemia, spinal cord ischemia, and gluteal claudication? Carotid subclavian bypass in case of left subclavian artery occlusion, especially in the following condition. If you have isolated posterior cerebral artery circulation, it's not completed the circle of Wilson. If you have a dominant left vertebral artery, if you have patent left for cabbage, which is internal mammary artery, left internal mammary artery for a cabbage, and anomalous subclavian or vertebral artery. So the recommendation in the elective basis of the TAAA, you have to make carotid subclavian bypass and to avoid occluding the left subclavian artery in a routine basis. It's better to detect preoperatively the blood supply for the spinal cord ischemia. Preoperative visualization and selective revascularization of a critical intercostal and lumbar artery. You have to detect the major intercostal blood supply, the major lumbar artery, which supply for the spinal cord, and later on you can make a reanastomosis or revascularization of this dominant and very important artery to avoid spinal cord ischemia. This picture is not related to our topic, but it is to detect type 2 endoleak, which is supplied by lumbar artery. And lumbar artery has a role in spinal cord blood supply. So this picture can detect the lumbar artery, intercostal artery, and you can detect also the major arteries which make blood supply to make your plan. Your plan is to reanastomosis and revascularization the critical intercostal and lumbar artery. We have to do sequential clamping in open thoracic AAA repair. That means in the first you make a clamp distal to subclavian and another clamp and later on above the visceral artery and later on below the visceral and so on. So sequential repair and distal aortic perfusion. Oxygenated blood is drained from the left pulmonary vein and reinfused into the left femoral artery through the procedure by centrifugal pump. The distal cannula is inserted over 0.035 in a flexible guide wire in left femoral artery through a groin incision. The blood could also be drained from the descending thoracic aorta and reinfused into the subdiaphragmatic aorta. The aneurysm is sequentially clamped, opened, and repaired in 4 consecutive steps, optimizing blood flow to critical aortic branch. That means after you have making a repair for a stage, you can declamp it and make perfusion to the viscera and intercostal and lumbars. So it's very important tips during open AAA repair, sequential clamping, and left heart bypass. Also, sequential clamping for the FEVAR or fenestrated EVAR is called staged fenestrated EVAR with missing branches. Difficult to detect which branch should be missed, but sometimes they are missing superior mesenteric left renal artery for 2 to 4 weeks and subcenter spare for the celiac trunk and one internal iliac artery and so on. Eurostar registry demonstrate in the fact that the use of the more than 3 stent graft correlate with spinal cord ischemia. That means you have to miss one branch. Experience of the total endovascular repair of the thoracoabdominal aneurysm demonstrated a significant relationship between incidence of the spinal cord ischemia and extent of the aortic coverage. Okay, this is the picture, and this is the missing for the celiac trunk, and later on you have stending the celiac trunk by covered stent after a space of 2 to 4 weeks. So increased number of the stents correlate with spinal cord ischemia, and increased length of the spinal thoracic aorta coverage increased risk of the spinal cord ischemia. Number 10, the end of the tips and the point how to make protection and preserve spinal cord blood flow. Intra and post-operative neurological monitoring and follow-up post-operatively at cardiovascular ICU with hemodynamic monitoring. Motor end plate, which stimulates the motor cortex and assists the motor response. Somatosensory end plate, less sensitive as dorsal horn sensory pathway, is less prone to be ischemic during spinal cord ischemia. And if you detect the somatosensory, usually detected from the tibial nerve at the ankle level, motor end plate through electrodes present at hamstring, tibial nerve, adductor hallucis, and the common peroneal anterior tibial nerve. This is the point of electrode which detects activity of the motor end plate, which is more accurate, and electrode for the tibial nerve at the ankle to detect somatosensory end plate, which is less accurate, being the dorsal horn sensory pathway is less sensitive and less prone to ischemia. And if we have a drop in the actual potential of their signals by 75%, that means ischemia. This is the green electrode for the somatosensory and the red electrode from the motor end plate, and you can detect, as we have told, hamstring, tibial nerve, adductor hallucis, common peroneal for the motor end plate, and tibial nerve for somatosensory end plate. Illustration detect development of the and monitoring of the motor end plate and somatosensory evoked potentialis during complex endovascular aortic repair. And we have significant change defined by greater than 75% decline and drop in the amplitude in motor end plate or somatosensory end plates. So what is the strategy if you have this drop and we have this ischemia? So during neurological monitoring and you have drop by 75%, the measurement is to drain the CSF and make its pressure lower than 5 mmHg, and to increase blood pressure to make mean arterial pressure more than 90 to 100 mmHg. This is the first step. If you are improved, so complete your case. If we have a problem, so we have to restore pelvic and lower limb extremity blood flow as soon as possible by removing a large sheath by continued deployment of the graft. If it has been improved, complete the case. Not improved, so you have to leave a one stent to be missed. So later on, after 2 to 4 weeks, you can complete the steps and insertion of covered stent to cover all visceral branches. So what is the conclusion? Minimizing ischemia time of feeder by revascularization of left subclavian artery before TAAA in routine basis, early pelvic and lower limb perfusion. Preserve spinal cord blood supply by limiting the aortic coverage. Preserve subclavian and hypogastric artery staged procedures. Increase tolerance to ischemia by pharmacological neuroprotection. Optimizing spinal cord perfusion. Preoperative cardiac optimization. Controlled hypertension. Reduced blood loss. Lumbar CSF drainage. Early detection of the spinal cord ischemia. Early neurological assessment status. Intraoperative motor end plate and somatosensory end plate assessment. And this is conclusive picture also. Number one, for prevention and treatment of spinal cord ischemia during open repair for thoracic abdominal aneurysm. This distal aortic perfusion obtained with left heart bypass. Number two, for permissive hypertension to maintain mean arterial pressure above 80 mmHg. Number three, for CSF drainage with automated and controlled system to keep it below 10 cm water or millimercury. And the last one is motor evoked potentialis, somatosensory evoked potentialis monitoring. Thank you very much for your attendance.